Hello and welcome to the next in our series of Hot Topics videos for pre-registration trainees. My name is Paul Johnson and this time I'll be taking you through 5 more essential interactions prescription scenarios. May I remind you that after each case has been presented, be sure to stop the video when prompted so that you can work out your answers. You may take as long as you like and can look up information in the BNF or other resources if you wish, but don't go straight to the answers. The best way for you to learn and retain information is to work out the questions for yourself. In our first Essential Interactions video, we covered interactions that affect key enzyme systems, such as drugs that affect the CYP3A4 pathway of the cytochrome P450 system. We also consider drugs which may have additive effects if taken together, such as drugs which are negative inotropes, or those which cause electrolyte disturbances, or those which may prolong the QT interval. We also advised you to revise MHRA drug safety alerts and updates from recent years to help you understand recent important changes in medicines usage. Before we move on to our next 5 clinical cases, let's remind ourselves of the process. You should imagine you are working in a busy pharmacy where you are presented with a number of prescriptions. You have access to some of the patient's medical information, and during your clinical checks, you notice a potential drug interaction. Using the patient information provided, you need to establish which are the interacting drugs. What is the mechanism of drug interaction? Or, to put it another way, what might happen if the 2 interacting drugs are taken together? And finally, which of the following courses of action is needed? Note the interaction, instruct the patient, or contact the prescriber. When deciding a course of action, you should consider factors such as, does the drug have a narrow therapeutic index or require careful dosing? Are the prescribed doses at the top or bottom of their licensed range? Is the patient elderly, or do they have renal or hepatic impairment, or other comorbidities? You'll need to pause this video when instructed in order to work out and note down your answers. Only then should you go on to the next slide to compare your answers with ours. Case 1 relates to Kylie Donovan, who you notice was started on ferrous sulfate tablets 4 weeks ago by an independent nurse prescriber. She brings in a further prescription for ferrous sulfate today, but tells you she has felt no better since starting them. She has little energy and feels tired all the time. She tells you that she also takes Maalox suspension occasionally for heartburn, but that she has run out and would like to purchase some more. Pause the video now and restart when you have your answers. The interaction here is between levothyroxine and iron, but also with antacids like Maalox 2, which contains salts of aluminium and magnesium. If levothyroxine is taken with either of these medications, the absorption of levothyroxine will be reduced. The tiredness Kylie reports could be because she has been taking all her medication together and may be experiencing symptoms of hypothyroidism as a result. Kylie should be advised to allow at least 4 hours after taking her levothyroxine before she can take either iron or an antacid. You may also consider advising her GP practice to run thyroid function tests to confirm whether she is currently hypothyroid. Case 2 concerns Mr. Samuels, who is 74 years old and has heart failure. Although his condition deteriorated a few months ago, his medication was adjusted and he has been stable on his current drugs now for 12 weeks. Mr. Samuels was visited by a locum doctor at the care home where he lives, and one of the care assistants today brings in the prescription shown. She tells you that Mr. Samuels has been experiencing cramps at night which have kept him awake. Pause the video now and restart when you have your answers. So what did you find? The first thing to note is that there are a number of potential interactions with Mr. Samuel's existing medication, such as carvedilol, enalapril and spironolactone, which all can cause hypotension, carvedilol and digoxin, which both can cause bradycardia, enalapril and spironolactone, which both can cause hyperkalemia, and spironolactone and digoxin, which can lead to increased levels of digoxin when taken together. However, he has been stable on these for some time, and lab results 6 weeks ago seemed to be normal. The interaction which should concern us the most is quinine and digoxin, however. Quinine is well known to increase plasma concentrations of digoxin by reducing excretion and the volume of distribution of the drug, which can cause a range of toxic symptoms, ranging from nausea and vomiting to death. This prescription needs referring back to the prescriber. Ideally, patients taking digoxin should avoid the use of quinine. However, if the combination is necessary, the patient should be closely monitored and the dose of digoxin reduced, usually by 1/2. It is also worth reminding the doctor that nocturnal cramps can be a sign of electrolyte disturbances, such as hyponatremia, and that is also worth checking. So Mr. Samuels could have repeat electrolytes and renal function tests again before commencing quinine. Case 3 concerns Mrs. Bradshaw, who was involved in an accident at work which injured her spine a year ago. Today she presents a prescription for MXL capsules, and she tells you that a modified release product has been given as an alternative to Severodol, because she often sleeps in the afternoon and often misses doses. Pause the video now and restart when you have your answers. There are several concerns with this prescription, but of particular importance is Mrs. Bradshaw's alcohol intake, which is excessive. Alcohol and morphine, when taken together, can cause CNS depression, which can also be made worse by taking diazepam. However, alcohol also has been reported to speed up the release of modified release preparations of morphine. Also, Mrs. Bradshaw has had her total daily dose of morphine increased from 20 mg to 30 mg. Add all this to the fact that she has been missing some of her doses of immediate release Severodol, and we can see that she is at a significant risk of morphine toxicity. This should be referred back to the prescriber to amend the dose. A couple of other points you may have noticed. Prescriptions for Schedule II controlled drugs should not normally request a supply greater than 30 days. Although not a legal restriction, this has been a strong recommendation from the Department of Health and the Scottish Government. And finally, Mrs. Bradshaw is at a significantly increased risk of liver damage from combining regular paracetamol and a high alcohol intake. She should be given advice and support about how to reduce her alcohol intake. Case 4. Mrs. Kumar brings in a prescription from the emergency dentist as she has been in a great deal of pain for 3 days. The dentist has told her she has a large abscess and must take antibiotics immediately or risk losing a tooth. She explains that she told the dentist that she takes warfarin following a recent deep vein thrombosis, but the dentist was adamant that she needed to take this particular antibiotic and to sort it out with her doctor. Mrs. Kumar is very worried about having another DVT and asks you if the prescription is suitable with her other medication. No prizes for guessing that the interaction is between amoxicillin and warfarin, but the important thing to work out in this situation is what you should actually do. The dentist insists Mrs. Kumar must take the antibiotic, but the high dose prescribed is quite likely to enhance the effect of warfarin. The reason for this is amoxicillin can kill off the normal gut flora, which is responsible for synthesizing vitamin K, which is required to produce clotting factors. Would an alternative antibiotic be an option? Well, the recommended antibiotics for dental abscess, according to NICE, amoxicillin, clarithromycin, phenoxymethylpenicillin, and metronidazole, all can interact with warfarin in the same way, and the interactions with each drug are marked as severe in the BNF. Our best option here, therefore, is to make sure her GP practice are alerted to the fact she will be taking amoxicillin and advise that she has more frequent INR testing, which may mean daily during and just after the course of antibiotics. Her warfarin dose may need to be adjusted in response to her INR results, and she should also be made aware of the importance of reporting any signs of bleeding or unexplained bruising. So let's move on to our final case. Mrs. Charles is a 35-year-old woman who has experienced migraine since her early teens. After trying a variety of preventative treatments, Mrs. Charles now manages her condition with sumatriptan, analgesics, and an antiemetic. Mrs. Charles' husband suddenly died 4 weeks ago, and she has been finding it hard to adjust to life without him. Her doctor feels she is becoming depressed and decides to prescribe fluoxetine, with instructions to return to him for a review in 7 days. Pause the video now and restart when you have your answers. So how did you do? The interaction you should have spotted is between sumatriptan and fluoxetine. Triptans and SSRI antidepressants are both linked to an uncommon adverse drug reaction known as serotonin syndrome. The syndrome can be life-threatening and is related to combinations of serotonergic drugs. However, the severest cases usually include combinations containing a monoamine oxidase inhibitor. So what would you recommend? It has taken some time for Mrs. Charles to find the right medication to manage her migraine, and on average she only takes 1 sumatriptan per week. The risks of developing serotonin syndrome are probably quite low, and it's likely the prescriber has already weighed up the risks and benefits and decided the combination is appropriate for her. As a pharmacist, it would be advisable to make Mrs. Charles aware of the symptoms of serotonin syndrome, however, and tell her to seek medical attention immediately if she suddenly experiences any of these. Symptoms of serotonin syndrome can be classified as neuromuscular hyperactivity, such as tremor, muscle rigidity, or unusual jerky movements. Altered mental state. This may include agitation, confusion, or mania. And finally, autonomic dysfunction, including tachycardia, increased blood pressure, sweating, shivering, or diarrhea. As Mrs. Charles is due to see her doctor in 7 days' time, you could advise her to mention to him that you discuss the interaction, or you may decide to notify him yourself. For those of you that have watched the previous Hot Topic video on drugs that may prolong the QT interval, you'll be familiar with categorization, a method we recommend to help trainees use the tables at the back of the BNF more effectively. Table 13 in the BNF is a list of drugs that may cause serotonin syndrome, and despite being quite a lengthy list, it is relatively straightforward to process once we've identified the major groups of drugs concerned. These tables come with a warning, however. The list is not exhaustible. Categorization, however, helps you relate the list to drug groups and mechanisms of action, so you're much more likely to understand what can happen rather than simply learning a list of drugs. Serotonin syndrome is sometimes referred to as serotonin toxicity, and it occurs when there is a lot of serotonin around or when serotonergic pathways are excessively activated. Therefore, any drug which increases serotonin or stimulates serotonergic receptors will increase the risk. This includes most antidepressants, SSRIs, SNRIs, tricyclics, tetracyclics, but most significantly monoamine oxidase inhibitors, which are associated with the severest cases of serotonin syndrome when used in combination with other drugs. This list also includes MAOIs used for other conditions, such as selegiline for Parkinson's disease. Triptans for migraine are serotonin agonists, and several of the stronger opioids are also indicated here. The latter group includes methadone. Does your pharmacy have methadone patients that also take an antidepressant? Do you ever consider that they are at an increased risk? Interestingly, serotonin antagonists can be indicated too. The 5-HT3 antagonists, including ondansetron, have been linked with serotonin syndrome in some rare cases when taken with other drugs on this list. So all that leaves are 3 nervous system drugs, the main one to remember being lithium, and 3 other drugs that don't fit in anywhere else, but which, other than dexamethasone, are pretty rare. So there we have it. Serotonin syndrome is usually associated with combinations of drugs that includes antidepressants, triptans, antiemetics, opioids, and also lithium. Thank you for watching this video. Please look out for future videos coming your way soon, and remember to email your suggestions for future hot topics to pre-reg training@buttercups.co.uk. You can also follow us on Instagram, Twitter, and Facebook. Have a great day.